Welcome to our NPTE Question of the Day series, presented by Typical PT. Today, we will be discussing a case study involving a pediatric patient with hip pain. Here's our scenario. A 7-year-old male presents with a 3-month history of progressive right-sided limp and intermittent pain localized to the right hip, groin, and anterior thigh. Pain worsens with running or prolonged walking and improves with rest. Parents report no recent trauma, fever, or systemic illness. The child is otherwise healthy, participates in youth soccer, and lives in a single-story home with no stairs. Objective findings include presence of antalgic gait with shortened stance phase on the right, decreased strength, grade 4 out of 5 hip flexion and abduction on the right due to pain inhibition. Upon palpation, there is tenderness over the right greater trochanter, no swelling or warmth. Imaging reveals AP and frog leg pelvic X-ray. There is also noted flattening and irregularity of the right femoral head, evident crescent sign and joint space widening compared to the contralateral side. For lab values, there is normal erythrocyte sedimentation rate, 12 mm per hour, normal C-reactive protein, 0.8 mg per liter, and a normal CBC, WBC 7,200 per microliter. In terms of social development, the child lives with both parents and one younger sibling. He previously enjoyed playing soccer, but this was discontinued due to increasing pain. Since then, he has shifted toward more sedentary play. For the school context, his parents also report that he has difficulty keeping up with peers during recess because of his symptoms. The question is, given the information provided, what pathology do you most likely suspect the child to have? Let's look at our options. A. Osgood-Schlatter syndrome. B. Legg-Calvé-Perthes. C. Transient synovitis. D. Slipped capital femoral epiphysis or SCFE. Alright, pause the video now and try to answer this question on your own. Once you're done, hit play again and let's check if you got it right. The correct answer is B. Legg-Calvé-Perthes disease. Let's go through why this fits perfectly. First, look at the patient profile. A 7-year-old boy. Perthes disease most commonly affects children between 3 and 12 years old, and it's seen more often in boys. That already sets the right context. Second, consider the clinical pattern. The child has a gradual onset of right-sided hip and groin pain, worsened by activity and relieved by rest. There's also a noticeable limp. Remember this, limited hip abduction and internal rotation is one of the classic signs of Perthes. And importantly, there's no trauma, fever, or systemic illness, which helps rule out acute or inflammatory causes. Third, let's look at the imaging findings. The X-ray shows flattening and irregularity of the femoral head, along with a crescent sign and joint space widening. Those are hallmark features of the fragmentation phase of Perthes disease, where avascular necrosis starts affecting the femoral head. Lastly, check the lab values. ESR, CRP, and WBC are all within normal limits. That means this isn't septic arthritis or osteomyelitis, since those would show elevated inflammatory markers. Now let's look at this table from the Physical Therapy Essential textbook, comparing Legg-Calvé-Perthes disease and transient synovitis. These two often get mixed up in pediatrics because they can look pretty similar at first. Both involve limping and hip pain in young kids. Starting on the left, Legg-Calvé-Perthes disease is idiopathic avascular necrosis of the femoral head. Basically, the blood flow gets cut off, the bone starts to die, and if left untreated, it can lead to deformity and a Trendelenburg gait. It's 4 times more common in boys aged 5 to 7, and symptoms usually last around 18 months. Clinically, we'd see hip or knee pain, limping, and in more advanced cases, a Trendelenburg gait due to weakened hip abductors. There's also the frog leg posture or sagging rope sign, plus limited abduction and internal rotation, especially when the hip is flexed. Those are red flags that should make you think Perthes. Pain often increases with passive range of motion. In terms of PT management, the focus is on protecting the joint, usually by using casting for 4 to 6 weeks, maintaining strength and aerobic conditioning, and promoting functional activity without overloading the hip. If conservative management fails, especially in children older than 8, an osteotomy might be indicated. Now, on the right, we've got transient synovitis, a temporary inflammation of the hip joint, often following a recent upper respiratory infection. This typically affects kids aged 3 to 10, causing acute hip or groin pain, limping, and sometimes a low-grade fever. The big difference is the timeline. Symptoms resolve within 7 to 10 days with rest and NSAIDs, and imaging is normal. So in our case, with symptoms lasting 3 months and showing femoral head flattening, transient synovitis doesn't fit. Now let's see why the other options don't fit. Osgood-Schlatter disease causes pain over the tibial tuberosity, not the hip. It's a knee condition in active adolescence, so it doesn't match our patient's presentation. Transient synovitis resolves in 1 to 2 weeks and shows no radiographic changes. Our case has a longer course and clear femoral head necrosis, so this isn't it. Slipped capital femoral epiphysis, SCFE, affects older kids 10 to 16, not 7-year-olds. Imaging shows posterior slip of the femoral head, not flattening or a crescent sign. So to wrap it up, everything about this case points to Legg-Calvé-Perthes disease, the gradual onset over 3 months, the patient's age, the localized hip and groin pain, and especially the X-ray findings of femoral head flattening and the crescent sign, all while having normal inflammatory markers. For your NPTE prep, remember these 3 quick differentiators in the notebook. Age range. Perthes hits around 5 to 7 years old. SCFE is 10 to 16. Timeline. Transient synovitis is short, about a week. Perthes lasts months. Imaging. Crescent sign equals avascular necrosis, which means Perthes. Now that you've gone through this case, take a moment to jot down all the key points in your typical PT digital notebook. Use it to organize your notes, highlight concepts you found confusing, or mark areas you want to review later. This feature isn't just for note-taking. It can serve as your personal reviewer, helping you track what you've mastered and identify topics you still need to strengthen, ultimately improving your retention and understanding. Thanks for watching today's question of the day. We're dropping new NPTE prep content every single day to help you pass with confidence. Follow us on Instagram, Facebook, and TikTok at typicalpt for daily study tips, quick reviews, and motivation to keep you going.